but I'm a geriatrician. So I don't actually have to think who's the vulnerable group because they all are. So I'm not actually so sure that I'm so good at talking about influenza and diabetes and respiratory, because I don't actually have to think all my patients need flu vaccination. And our struggle is actually to highlight to them, because when they come in to their 8-monthly appointment, they've got a list of problems as long as your arm, and you have to decide how to prioritize, and influenza often doesn't get mentioned. So we need a lot more efforts. So these are the vulnerable groups. I think it's been mentioned before. So you have pregnant women, children aged 6 months to 5 years, older people. Usually we say 65 years and over. And every time I do a talk on older people, the question is always, what's the definition of old? So please don't ask that. So chronic conditions and healthcare workers. So these are the vulnerable groups. So these, so as our first speaker mentioned, the vulnerable groups would be actually, the at-risk groups will be the first 4, and then these are the people these are the high-risk groups, and these are the at-risk groups. So most of us in the room would be considered at-risk groups. So for older people, particularly the ones that I look after a lot nowadays, it's more and more older people are turning up into hospitals. And when you go to the emergency department, there's usually a lot of older people sitting there waiting for a bed on the geriatric ward. We no longer accept patients on the geriatric ward because we're always negative 813. And we weren't so bad. I visited my friend in Aberdeen, and she's always negative 26. So they always have to identify another alternative ward to go to, so that there wasn't too many older people waiting in the emergency department. And the problem with flu and older people is older people tend to have comorbidities. The immune system has is getting older, so works less well. So they are at high risk of developing complications. And they often don't present with the classical signs. So fever is not something you get. And you can't say, if there's no fever, it's not an infection. If there's no fever, there's no influenza. That is clearly not true. And sometimes they don't present with any signs of an infection. Instead, they have they actually present with another medical problem, exacerbation of the heart failure or the COPD, or even a heart attack or a stroke. And it can be challenging and extremely difficult to detect. But as COVID has taught us, because we also did this same thing happened with COVID, we'll let the patient on the ward without noticing they've got COVID. And next thing you know, the whole ward has COVID. And so, and this had happened for a long time for flu, but we just kind of call it a hospital-acquired pneumonia and treated them with really high dose kind of strong antibiotics instead of even tweaking that flu was perhaps the offending agent. So COVID has really changed the way we think about management of infections in our older adults. So this is a study that Prof. Zamri has flashed up earlier. So it's done by one of our young, she's not young anymore, but when she was younger, infectious diseases specialist who was interested in older people. And we basically got, one of our microbiology researchers actually did this surveillance study for nearly 4,000 people who attended our own primary care clinics. So our hospital actually has a primary care center attached to it, which also provides for the same catchment area as the teaching hospital. And so he's kind of screened everyone for a range of viruses, and he found amongst them about 400 people who actually screened positive with flu. So these people actually have upper respiratory tract infection symptoms. Then basically we found that, as mentioned, those who tested positive for flu, the older people were less likely to have fever. And then, but the older people, what was really shocking, and that we beggars believe, was that we only had 50 people out of 50 older people out of the 400 people who tested positive for flu, and 5 of them died. So that gave us a 1-year mortality rate of just someone turning up to the primary care department with upper respiratory tract infection, testing positive for flu. They ended up 10% were dead by the end of 1 year. We were like, wow, that's serious. I can't believe nobody's detected this sort of rather scary mortality. And then when we actually looked at how many of them got hospitalized and died, because competing risks, we had to add death into the hospitalization data. So more than a quarter of them were hospitalized or were dead by the end of them. That was rather shocking data. And we hoped the policymakers would wake up, but nothing happened. Maybe it's because we actually published this too near the COVID-19 pandemic. COVID is a very convenient excuse for everything. So we do know that influenza causes severe diseases in older adults. And this landscape is changing because more and more people realize that flu doesn't present as the classical symptoms in older adults. And people with flu might not die of the immediate respiratory complications. They die later of something else. So basically, the patients who had flu who are older often have other chronic diseases, as I mentioned earlier, and but being older alone actually is an independent kind of associated factor with mortality. And then about 70%, over 77% of people who die because of flu are older. So hopefully this justifies why we are targeting older people when it comes to getting vaccines, influenza vaccines. Older people are far more likely to die. So this is not Malaysian data, this is US data, and that just confirms what was said earlier. So when you're talking about symptomatic illnesses, not many are old because they don't present with symptomatic illnesses. And medical visits. But when you look at hospitalizations with flu, whoops, that goes right up. And then deaths is the older people who actually really die from influenza. Okay, so there are disease burdens beyond respiratory disease that we are now noticing that's emerging with influenza. We actually knew about this even before the days of COVID. But COVID actually made the world wake up to the fact that influenza wasn't just about respiratory disease, it's a systemic disease. And so what's very common in older people is after, a flu, which lays them down or lays them up for 1 week if they don't have complications, 2 or 3 or 4 weeks if they have complications, they become deconditioned. And they might struggle to get back to pre-morbid conditions, physical condition, we call it deconditioning. And that might be the start of a downward spiral of deterioration. They become more frail, more disabled, and then eventually, and that leads to an early grave. So we now call this a domino effect of influenza, and it's not really that different from COVID. So what you're looking at, traditionally we were looking at the respiratory complications, so we thought exacerbation of COPD or asthma and then pneumonia, that was what flu causes. But actually if you have diabetes, then your diabetes control goes haywire, and then you get all these problems with diabetic complications. If you have the inflammation, the inflammatory response actually triggers cardiovascular complications, hypercoagulability, leading to strokes, exacerbation of heart failure, sometimes myocarditis, and acute myocardial infarction. They can get dehydrated and get renal complications, that's quite common. They might get neurological complications such as seizures, Guillain-Barré syndrome, and encephalopathy. And of course, as I mentioned earlier, the deconditioning that leads to declining activities of daily living, and a downward spiral of deterioration that we see in geriatrics. So you have respiratory complications, diabetic complications, cardiovascular complications, and renal complications. The cardiovascular ones are what we're very, very interested in when it comes, because having an incidence of flu will increase your risk of getting a heart attack, stroke, thromboembolism, heart failure, and myocarditis. And the risk of a stroke and a heart attack might not be immediately in the first few weeks after the influenza. It might extend for weeks or months or even a year later. Okay, so how about influenza vaccine in older adults? So a lot of times people say, don't give to the older people. They can't mount the immune response. So the influenza vaccine is a little bit less effective in older adults. So there's a reduced immunogenicity. But that doesn't mean that they don't benefit from the influenza vaccine. And what you actually see is that they benefit more from influenza vaccine, because remember, you're looking at absolute numbers. So they are the ones who go to hospital, they are the ones who die. So if you give them influenza vaccine, even though the immunogenicity is lower, but the actual real benefit from prevention of death and hospitalization is much bigger. So that's the bang for your buck. And remember that all our hospitals are really, really full, and influenza in some ways contribute to that fullness, though it's not really that well measured. So it's a very cost-effective thing to do. So I mentioned the immune response. I'll skip it in terms of time. So I'll just go through the evidence that backs all this stuff about influenza vaccination for high-risk groups, just very quickly. Some of it is repetition. So in Singapore, you do have the National Adult Immunization Guidelines, which actually recommends influenza vaccine for older adults. Okay. And Malaysia, we kind of have the same thing. We also have adult immunization guidelines that are actually produced by the Malaysian Society of Infectious Diseases that recommends vaccination, but not just for 65 and over, 50 years and over. The rationale is that at 50 years and over, your immune system starts deteriorating, the complications starts going in. Because the government didn't fund it, it's out of pocket. Everyone should really have it. And this was a position paper that Prof. Sambri mentioned. And then we actually went on to, because we keep wanting to create that noise and that pressure. So when the position paper didn't really have enough impact, we worked together and said, let's come up with guidelines for prevention and get this published in a peer-reviewed journal. Because one of the things that pushes funding is whether you have the evidence. And of course, we will never, ever get a randomized controlled trial of flu jabs versus placebo and done in Malaysia. That would be unethical. So how are we going to generate this evidence? So the best possible evidence we thought was an expert panel consensus reviewing all the evidences. So we actually published this, and we're happy to share it with anyone who wants to use that as ammunition to actually ask for vaccination in their country if it's not already funded. So this is the guidelines development group, and it was actually quite a thorough scientific process. And so these were recommendations over 60 years and over. So 60 years and over because Malaysians die earlier than the developed world. So we can count backwards from time to death rather than forwards from time from birth. Okay, and comorbidities. So if they say we have no money, we can't fund for the whole 3 million older people in Malaysia today, then we can say you target the ones with comorbidities. And then we actually ask people to take whatever's available. And then we also talk about post-exposure prophylaxis. And then particularly for residential care homes, because what happens is occasionally flu comes and then they don't test. So like half the care home either empty out into the hospital or pass away before they get to hospital. And so big things need to be done to prevent that happening on a recurrent basis. And then so immunocompromised, we address that specifically. And also because to localize it, we actually included the Hajj. And we also talked about particularly residents and also workers in care facilities having vaccines. And then and addressing outbreaks as well, that as soon as you have 2 or more cases, you need to test. And then everyone needs to be given post-exposure prophylaxis. So if you're interested in these guidelines, here's a QR code for you to scan. Okay. And this is just a summary of the guidelines. So there are other guidelines, international guidelines, the GOLD guidelines, everyone's familiar with. And in fact, the respiratory physicians, I believe, are the best people at advocating for influenza vaccines. But for the heart specialists are less good at telling the patients have influenza vaccine. But there's actually a huge body, a huge number of professional bodies that already support the use of influenza vaccine for people with heart diseases. And then there's also a huge number of bodies that actually support the use of influenza vaccine in diabetes. And so just a reminder, vulnerable groups and Singapore immunization schedule, Malaysian immunization schedule. Thank you.
Thank you very much. A similar question online, and again, encourage people either online, because remember we've got 300 people watching. How good are the other specialists, the cardiologists, renal physicians, endocrinologists supporting your cause, they all should know because it's worse, but do they actually get on board and are they actually major advocates for what you're pushing?
That's a really good question. So we regularly hold forums, and the forums always contain an endocrinologist, cardiologists, and we kind of leave out the respiratory physicians now and then because they're already so convinced, but mainly getting at the cardiologists and the endocrinologists to join us in public forums and also in talks to really encourage people to take up influenza vaccine if they were in the high-risk group.
A similar experience in Australia when the obstetricians came on board for pregnancy after the pandemic made a huge difference and a good uptake. So you need the specialist. We need our colleagues on board. Question? Yeah, thanks.
Thanks very much for your presentation. Given the under-ascertainment of influenza in the elderly, how useful for decision makers do you think evidence, for example, ecological evidence of excess deaths, excess specific health conditions during flu season is to help make your case?
Yeah, that's an excellent question. And we were actually somewhere near there when it came out at the beginning of the COVID-19 pandemic. So we knew about this epidemic that happened before the COVID pandemic, and our COVID didn't really happen in the first wave in Malaysia. So our public health physicians actually got data from the National Statistics Department to look at excess death during the first wave of the COVID-19 pandemic compared to the first wave during the flu epidemic. And in both cases, there was overall reduction in death in the entire population because people didn't die of road traffic accidents. But when they took 60 as an age cutoff, there was no excess death in the first wave of COVID-19 for over 60s, but there was definitely an excess death of around about 2,000 people. So these were not confirmed to have influenza, but the excess death was there. So it's like, whoa, it's like the excess winter deaths. So, but because now we have very inconsistent stuff with influenza and our system is now reeling from the aftermath of COVID, I think it'll be a while before we are able to churn up the mechanisms and people retire. And it'll be a while before we can churn out the mechanism to actually get that excess death sorted again.
Question from the floor here. Thank you. Just here on the left, on your left.
Yeah, thank you. So I'm Christopher from Indonesia. So I'm interested when you and Prof. Zambari in Malaysia and Singapore had a campaign, create push through government for this kind of recommendation and even make a petition. Is there any, what we see in pediatric, there are like people against that kind of campaign, the anti-vax. What about in adult and elderly? Is there anybody opposing your campaign or something like that? My first question. And the second question is that because your presentation is impressive, but it's very fast. So is it possible for us to get your presentation, especially the guideline when I want to scan? You skip so much, so whether you can share it with us. Thank you.
Maybe you can get the organizers to put
so I think
QR
the plan
code.
is that all of these are going to be available with consent of presenters. We would anticipate APACI would make all of these available, and so you'll be able to scan that and get them. So
opposition we don't get. Enthusiasm we also don't get. So the opposition is towards the COVID-19 vaccine. There's still a lot of anti-vaxxers out there, and unfortunately, but what we have found is because we actually have mass immunization programs going on in Malaysia now. So we started off with a foundation in Penang funding 5,000 flu vaccines actually during the first wave of the COVID-19 pandemic. And the 5,000 just went like that. So the Selangor state government then took on themselves to fund 10,000 the last 2 years, but only targeted at people who can't afford it. And then this year in October, the Malaysian Society of Geriatric Medicine actually provided a grant for hospitals to hold the International Day of Older Persons. And then our advocacy group then worked to actually get the hospitals to push for influenza vaccines. So the hospitals will put up like 50 free vaccines, 100 free vaccines, and the uptake was extremely fast, overbooked as soon as it's actually released. So yes, there is appetite for influenza vaccine. When we will achieve the dizzy heights of the numbers achieved by Thailand, will be another, something to watch.
Thank you very much.